He's the Chief Executive Officer of Abyad Medical Center in Lebanon. Dr. Abyad is a well-known geriatrician in the local Lebanon region. Internationally, Dr. Abyad is held different leadership positions in different organizations, societies, and committees. Dr. Abyad have great contribution to a lot of initiatives. Dr. Abyad have more than 150 publications. We're happy to have him here with us today. He can give us a talk about an updates in hypertension management in elderly. What are the appropriate targets? Go ahead, Dr. Abyad.
Good evening, Masal Khair. Assalamu alaikum. It's a pleasure and honor to be with you, Dr. Abdullah, with your fourth geriatric conference in Abu Dhabi. We should have been in person, but unfortunately, owing to COVID, we are going to be virtual. It's nice to be with you all, and it's always a pleasure. I'm going to take you through a small journey on update on hypertension management in the elderly, and we are going to touch through a simple case and see what are the practical points in management and what are the research behind why we are managing our elderly patient like this in hypertension in general. The case that I would like to share with you is the one of my patient. This is one of my dear patient. He died recently, 1 year ago. When I saw him first, he was 84 years old, and he's functioning independently, although he had history of fall twice the previous year, with a blood pressure of 166 plus over 60, with atrial fibrillation, heart rate 88, CT of the brain revealed old lacunar infarct, and echo ejection fraction, echocardiography ejection fraction, it was at 60%. The questions that will rise when you see such a patient: will you start antihypertensive treatment? What type of treatment you will start? To what blood pressure target you want to lower the blood pressure? You want to lower it to less than 110, less than 120, less than 140? And will he benefit? We are trying to answer those questions in a very methodological way and in a very scientific way, showing some research related to those questions. Looking at the epidemiology of hypertension, it will tell you why we are so much interested in hypertension. There is a dramatic increase in the prevalence of hypertension with aging. By age 70 years, the majority of people have hypertension. It affects around 1 billion people worldwide, so it's a huge number. In the States, for example, about 1 in 3 adults has hypertension. If you are 55 years old and non-hypertensive, you have 90% lifetime risk of developing hypertension. So the risk is high. It is #1 reason listed for office visit, and it contributes in the state alone to almost like 500,000 admissions per year. In addition, it is one of the leading cause contributor to death, myocardial infarction, stroke, vascular diseases. When you want to treat a patient, you want to consider his life expectancy, how long this patient is going to live. In our particular patient, he is around 85 years old. It's expected that he will live up till the age of 92, which he did. He died at the age of 90, so he lived 5 years after I saw him the first time. Looking at the pathophysiology quickly of the disease and some of the consequences in older adults, hypertension is characterized by an elevated systolic blood pressure with normal or low diastolic blood pressure due to age-associated stiffening of the large arteries. There is an increase in systolic blood pressure and pulse pressure, increase in left ventricular mass and wall thickness, arterial stiffness increase, and the calculated total peripheral resistance will increase as well. On the other hand, there is a decreased cardiac output and heart rate. There is decreased renal blood flow, plasma renin activity, and angiotensin II levels. There is decreased arterial compliance and blood volume, and diastolic blood pressure normally decrease. Hypertension is a potent risk factor for cardiovascular events in the elderly. And the higher your systolic blood pressure, the higher your risk of developing coronary heart disease and mortality secondary to coronary heart disease as you age. The question that of interest to a lot of us is when to treat the patient and when not to treat. The specific blood pressure at which antihypertensive should be initiated in the elderly is unclear. Do you want to reach a target of 140/90 in person between 65 to 79? Some say yes, some say no, you need to go lower. Or do you want a threshold of 150/90 in people above the age of 80 years? Again, there is controversy among scientists. We know, all of us, that there is a G-curve associated with diastolic hypertension, meaning the hazard of side effects from blood pressure on the diastolic side is a G-curve. So the lower the diastolic blood pressure, the lower the possibilities, the higher the possibilities of developing side effects and complications from the diastolic blood pressure. And when the diastolic blood pressure goes above certain limit, above 100, again, the risk increase. For systolic, the J-curve is less, it is more flattened, except when you go above the age of 70 and above the age of 80. Here again, you find when the blood pressure go lower than 130, there is higher hazard of developing side effects from the blood pressure. There are recommendations, as you know, the recent recommendation of the GNSC 8 recommendation. There are data behind this recommendation. And one of the important data behind this recommendation is this paper in the New England Journal of Medicine, which look at the study of treatment of hypertension in patients 80 years of age and older. So the trial was specific for patients above the age of 80 years. What they did, this is called the hypertension in the very elderly trial, HIVAT, International Multi-Center Randomized Double-Blind Placebo-Controlled Trial, where they included patients only above the age of 80. And this is trial, very important trial. And they looked to decrease blood pressure at least 20 degrees. They started with diuretics, indapamide first. If the patient is not controlled, they added perindopril, 2 milligrams, and increased the dose of pyripondril until they controlled the blood pressure versus the placebo, which they received the placebo medication. What the studies revealed, actually, and this is very important, there are marked decrease in fatal and non-fatal CVA, marked decrease in deaths from CVA, marked decrease in all-cause mortality, any heart failure, and any CV events compared to the placebo group. So the intervention group fared much better compared to the treatment group. So the blood pressure control in patients above the age of 80 years of age provide benefit. And this landmark study really paved the way for better management of elderly patients above the age of 80. So the HIVAT is showing improvement across all different outcomes, all strokes, stroke deaths, all-cause mortalities, cardiovascular deaths, cardiac deaths, heart failure, and cardiovascular events. So the marked decrease in the risk of developing those problems. So HIVAT demonstrated the treatment of hypertension to goal blood pressure less than 150/80 in patients greater than 80 years old was safe and effective. But what about the lower blood pressure goal? Can we go lower? And is there any improvement if we go lower? And what about the patient between the age of 60 to 80 years? Here we have those two studies, the SHAP and the CIS Europe studies, whereby they compare patients between the age of 60 and 80, and they try to drop the blood pressure to below 20 degree below current level. So if it is 160, they drop it to 140. If it is 180, they drop it to 140. And the follow-up was for 5 years. Both studies revealed there are decreased in combined fatal and non-fatal strokes, 36% in the SHAP and 42% less in the CIS Europe. And the combined fatal and non-fatal heart failure, SHAP revealed almost 50% drop in those episodes, and CIS Europe showed 29% drop in the events. There are studies trying to adjust blood pressure even lower than 150, lower than 140, and this is the JATOS. JATOS is a Japanese trial to assess optimal systolic blood pressure, and the VALISH studies. And the goal is to compare strict control of blood pressure below 140 versus moderate control greater than 40, less than 160. The same for VALISH, Valestan, Algeria Isolated Systolic Hypertension studies, whereby they try to drop the blood pressure in the strict management less than 140 and the moderate between 140 and 150. What they found in the Japanese trial to assess optimal systolic blood pressure, they found no difference between strict treatment and mild treatment group. Same was the study, the Valsartan and Algeria Isolated Systolic Hypertension studies. Again, there was no difference between strict and moderate control of hypertension. And those are the three studies. The most important study, the SHAP, the CIS Europe, and the HIVET, and the blood pressure that they achieved during the trial was around 143 for the SHAP, 150 for this CIS Europe, and 144 for the HIVET. So the drop was an average of 20 degrees and to the almost 140. With dropping blood pressure below 140, the VALISH, the JATUS, and the HIVET and the SHAP saw no harm with dropping the blood pressure below 140. But they did not assess how much lower you can go. And this is why we need more data. We need more data and be able to judge to which level we can go lower with elderly patients. This is evidence-based guideline for the management of high blood pressure in elderly in general and in adults. For the elderly above the age of 60, we like blood pressure below systolic blood pressure of 150, diastolic blood pressure less than 90. And patient with diabetes or with chronic kidney disease, then we like stricter control of blood pressure to less than 140 if possible. This is comparison of recent guideline statement between different studies, GNC7, 8, ASK, and the CHAP. And again, we noticed that GNC8, the control was less than 140 over 90. They changed it to 150 over 90 in people between the age of 60 to 79. And the European, they like it below the 140 over 90. If patient above the age of 80, across the board, most recommendation and guideline say below 150 over 90, not lower than that. There are recent studies in the literature. This is a study from September 2020 in the JAGS. They saying we need really to move toward a more personalized medicine approach in treating hypertension in the elderly. We cannot rely only on trials and recommendations, because what they noticed in this comparative studies, they found that the hazard of treatment of hypertension increase the more the patient has comorbid conditions or the patient is frail. So in a frail patient, you see the hazard from any type of treatment, from regular treatment, strict treatment, or moderate treatment. There is marked increase in the hazard of side effects from treatment of people with hypertension. Again, this is another study in the JAGS in September 2020. Here they did a cross-sectional studies in 24 ambulatory care centers in the UK, and the number of patients was almost like 16,000 patients. And they came with a conclusion that the more comorbid conditions the patient has, the more uncontrolled blood pressure, the more multiple problems, the less likely the patient will benefit from treatment of hypertension. And the benefit is showing from treatment is really minimal across the board of those three studies. So the conclusion they came with this study is that a possible unintended consequence of blood pressure criteria used in trials attempting to answer different primary questions is that for elderly patients, no trial evidence exists to inform treatment decision and routine practice. So in routine practice in elderly patients, you cannot rely only on guidelines. Caution should be exercised when applying results from existing trials to patients with frailty or multi-morbid conditions. Again, comparing intensive versus standard blood pressure control in adults 80 years old, again, the same conclusions they came with. This is a big study, and they came, this is a secondary analysis of all the trials, SPRINT trial and other trial. And what they found out is in adult age 8 years or older, although intensive decreasing of systolic blood pressure may improve the risk of major cardiovascular event, MCI, and death with increased risk of changes to kidney function, the cardiovascular and mortality benefit of intensive systolic blood pressure control may not extend to older adults with multimorbid condition and with cognitive function which is lower. So we still have significant controversy over target of initiating and goals of hypertensive therapy in the elderly. We have not reached consensus yet, and we really have to rely on personalized medicine and individualizing the patient. And my recommendation for you is to try to do something called first, look at risk stratification, look at your patient, whether he's frail or not, look at his age, not only the chronological age, you look at the physiological age. You may have somebody at the age of 100, but yet he's functioning like somebody at the age of 60. Look at the risk of fall, whether the patient has the risk of falling. Look at adverse effects and polypharmacy as well. It's important to keep in mind that lifestyle modification is very important even in the elderly. Non-pharmacological lifestyle measures should be encouraged in older adults, both to retard the development of hypertension and as an adjunctive therapy with hypertension. Some of the intervention may even lower blood pressure by almost 10%, which is very good actually, including regular physical activities, sodium restriction, weight control, smoking cessation, and avoidance of excessive alcohol intake. So what medication you will give our patient? And this is a question now. I mean, among the favorable medication for the elderly, of course, is diuretics, ARB, ACE inhibitors, long-acting calcium channel blockers. In addition, you have to remember in elderly in general, beta blockers are not recommended for uncomplicated hypertension in the elderly. So it is better to avoid beta blockers. And like everything with elderly, we have to start in smaller dose, titrate up slowly to avoid postural hypertension. So choice of initial medication, as we said, this is evidence-based medicine. For initiation of antihypertensive drug therapy, first-line agents include thiazide diuretics, calcium channel blocker, ACE inhibitor, or angiotensin receptor blocker. Those are the first-line medications. In general, again, this is recommendations that we have to keep in mind. A lot of cardiologists sometimes prescribe ACE inhibitor with ARB together. In the elderly, it is better not to combine this combination because it is potentially harmful, especially for the kidney, and it may lead to further complications. So what to use in our patient? In a conference, I would ask you to give me this answer, what medication you will give. I'll give you the answer so that to make it easier for you. Shall we use thiazide diuretic in our case? Problem with thiazide diuretic, it may cause sodium and water depletion and may promote orthostatic hypotension. And as we know, in our patient, he had fallen twice before in 1 year. It can cause hypokalemia, hypomagnesemia, and hyponatremia, which may increase arrhythmia. And in our patient, he has atrial fibrillation. So we have another complication. The elderly have a tendency toward hyperuricemia, glucose intolerance, and dyslipidemia, all of which are exacerbated by thiazide. Beta blocker, its benefit in the elderly has not been convincing. There are some studies, but benefit has not been convincing. So unless you're obliged to use beta blocker, avoid beta blocker at all costs. In the elderly, they may have a role in combination therapy, especially with diuretic in some particular patients. How about calcium channel blockers in Mohammed? Problem with calcium channel blockers is vasodilatation, ankle edema, headache, postural hypertension, heart block, an elderly patient with underlying conduction defect, and our patient has conduction defects. First generation calcium channel blockers should be avoided in patients with left ventricular systolic dysfunction as well. How about ACE inhibitor? ACE inhibitor is a good choice. However, ACE inhibitor may cause again hypotension, which may lead to further fall, chronic dry cough, and rarely angioedema or rush. Dry cough is really a nuisance, especially in the elderly. We see it frequently. Renal failure can develop in those with RAS, and hyperkalemia is another side effect. So our patient has atrial fibrillation. What to use the best medication to use in this particular case is to use angiotensin receptor blockers. It's very useful in patients with recurrent atrial fibrillation and hypertension. And this is what we did use. We used ARB in this particular patient. It was well tolerated, it protected his kidney, and in general, ARB reduced mortality and morbidity in our heart failure patients. Another alternative is to use direct renin inhibitors, although this medication may be expensive, but it has the same effect as ARB and it's not available everywhere. So in our patient, we answered most of the question. Will you start antihypertensive treatment? Of course, we will start antihypertensive treatment. It's healthy and well, has some problem. We started ARB. We reached the target of 145, which was fine with us. And he definitely felt better on treatment and he lived another 5 years. So the take-home messages that I would like to leave with you are 10 actually. You have to remember that there is a dramatic increase in hypertension prevalence with aging. By age 70 years, most of the patient has hypertension. In older adult, hypertension is characterized by elevated systolic blood pressure with normal or low diastolic blood pressures. Hypertension is a potent risk factor for cardiovascular event in the elderly. There are numerous randomized controlled trials showing substantial reduction in cardiovascular outcome in cohort of patients 60 to 79 years old with antihypertensive drugs therapy, though the effect of all-cause mortality has been modest. Although increase in treatment and control on blood pressure has occurred in the last few decades, however, still blood pressure control in most of the patients suboptimal in a lot of countries. Non-pharmacological lifestyle measures are very important and should be stressed. Unfortunately, this is not stressed very much in a lot of practices owing to busy practice or unavailability of time of the physicians. Although specific blood pressure at which antihypertensive therapy should be initiated in the elderly is unclear, a threshold of 140/90 in patients between 65 to 79 and less than 150 in patients above the 80 years is a reasonable target. Diuretic ACE, angiotensin receptor blocker, calcium channels, and beta blockers have all shown benefit on cardiovascular events in randomized trials among elder cohort. Choice usually is dictated, as I said, by efficacy, tolerability, comorbidity, and cost as well. Initiation of antihypertensive treatment in the elderly should be at the lowest dose possible with gradual increment as tolerated. And finally, the high prevalence of both cardiovascular and non-cardiovascular comorbidity among the elderly dictate need for great vigilance to avoid treatment-related side effects of antihypertensive. And I would like to thank you for listening to me. I hope I did not bore you, and thank you a lot. And pleasure to be with you.
Thank you, Dr. Abyad, for this interesting presentation. Thank you for summarizing all this literature evidence regarding what is the best target for our elderly patient. There is a question answers will be left to the end after the third speaker for the second session. So now we'll move to the next speaker. Is for the next topic is Dr. Fatima Al Hajeri. She's consultant obstetrician and gynecologist at Cornish Hospital in Abu Dhabi, United Arab Emirates. Dr. Fatima Al Hajeri, she is the Saudi board certified in 2010, and she had diploma in obstetric and gynecology ultrasound from Cardiff University 2017. Have special interest in advanced gynecology, ultrasound, 3D, gyne ultrasound, and MIS surgeries. Dr. Fatima Al Hajeri will give us a talk today about common gynecological problems in elderly female office-based approach. Go ahead, Dr. Fatima.
Okay. So I'm going to talk today about common gynecological problems in elderly female office-based approach. Actually, it's a very interesting topic because in the clinic, they are the minority, those that we see them in the clinic, and we deal with them. The maximum number of patients we are seeing are the young patients, but when they come to our clinic, we need to give them special care. We don't deal with them like others. They need to have more time, more care, and we need to be very careful with them. So we need to define aging woman. And so I'll talk a little bit about the definition of aging woman, which you know better than me. UAE statistic of population distribution, especially aging women, and the key clinical issue introduced by aging. Aspect of gynecological care unique to older women, and then after that, a conclusion. So gynecologists will invariably face rising number of older women in their practice whose care is a precarious situation, and it needs special skill to deal with. Per the institution of medicine, the nation faces an impending healthcare crisis as the number of older patients with more complex health needs increasingly outpace the number of healthcare providers with the knowledge and skill to adequately care for them. Quality of life and functional independence, central issue in geriatric care, are a natural part of specialties focus. So older patients typically discuss only minority of their many health problems, and they will not say it freely because especially in gynae, they feel shy to express it. In addition to that, there is other problems that they might face, but they don't give it that importance to express and say to us. May not inform us, as I said, especially the gynecologists. Common, often unprotected conditions relevant to gynecologist care are, one is undernourishment. And you can see that most of our geriatric patients are really underweight unless taken care for them, but in not the way we want it if they developed obesity, but they are undernourished, and it's a complex situation that might be not only because the care they are getting, but because of the complexity of their cases. Cognitive impairment, which is very important, vision impairment, hearing impairment, balance impairment, and other problems that might affect them, like physical, emotional, financial, sexual abuse, and negligence, even self-negligence, dysphagia, and frailty. So prevalence rates vary widely by definition and population. The social support will play a role on defining or finding a clear percentage of those neglected complaints. In UAE population, we know that we are a younger population because most of our population are very young because they are workers. So the minority are the geriatric age, and they are almost equal among male and female if we are talking about more than 65 years old. So the goal of care for robust, fully functional older adults are essentially the same for younger patients when they come to our clinic. So always they need to be screened for problems. We need to treat their condition and their complaint and provide prevention if we can, and we could recognize their real situation and status. In those with physical frailties, multiple comorbidities or cognitive decline and primary goal shift to optimize function and quality of life. Thus, the provider must make an effort to fully understand the patient level of function, because this will play a big role in for us to take the history, examine her, and decide the type of treatment she needs, because at the end, it depends on the level of function. The encounter might best start with, what do you enjoy doing usually? Does anything prevent you from doing what you are doing now, or what you would like to do now? Frailty is a state of progressive decline and dysregulation of molecular, cellular, and physiological system. When a critical number of impairments develop in mobility, strength, balance, motor processing, cognition, nutrition, endurance, and or physical activity, a person becomes frail. So she is more vulnerable to disability, dependency, fall, and even death. So when a critical number of impairment develop in mobility, strength, balance, motor processing, cognition, nutrition, endurance, physical activity, a person becomes frail. And this is very important, especially when they visit us in the gynae clinic, as I mentioned. Definition vary, but if we have 2 out of 3 I mentioned, we consider them frail. Even when disease prevalence is higher, the utility of cancer screening decrease. So when we said that when they come to our clinic, we would like to screen for cancer or screen in general for any disease. treat and prevent. So for screening, it's a little bit with argument because of the age and the duration from the disease itself, occurrence and the occurrence of the disease and the symptom. So utility of cancer screening decrease in advanced age, and we'll see that among many societies. Inconsistency in guidelines are not surprising since data are sparse. This heterogeneity can be shown now. Upper age limit guideline from selected organizations state that if life expectancy is 5 years, screening is contraindicated, meaning that anything more, less than 5 years, screening is contraindicated. Although we can see from this graph that the population, if they are aging 95 and less, they will live more. They have the capacity to live more than 5 years. So if she reached 65, she can live for 5 years till she reach 80 and so on. So after 95, the expectancy is less than 5 years, and here we need to stop the screening. But as we will see now in the coming table, screening is stopped, or it's considered not really indicated after 80. So in general, all the guidelines will suggest screening from 70 to 80 years old, if on average health. All three organizations recommend against vaginal cancer screening after a total hysterectomy without cervical and epithelial neoplasia. So if she didn't have 3 consecutive abnormal pap smear, no need to screen her after that. For colon cancer, it will be every 10 years, but it carries very low risk for perforation, 1 in 1,000, serious bleeding 3 in 1,000, and cardiorespiratory event 5 in 10,000 during the procedure. So for cervical cytology, the American Society will suggest doing the pap smear till 65, 70 years old, and we will stop if she have 3 consecutive negative results. And for the task force, they will suggest to do it till 65 years old, and the same for ACS. HPV, no need to do the screening for them since we are doing the pap smear, and they don't have any prognostic data to encourage doing HPV. Mammogram will be done all over while she's alive, and they are not really having a strong recommendation to stop doing that. Colonoscopy, as I mentioned, every 10 years. So what we'll do in outpatient care? For sure, we need to take a history, and the history needs very good communication with the patient. And usually we will see that she's in her speed a little bit slow, learning and recall of a new information, finding word and reaction time needs some time. Physician by that need to be very careful with that. So he need to speak slowly and clearly, keep repeating, eliminate all the source of interruption in the clinic, repeat the information till he makes sure that she could understand what we meant by that, and relate new information to old and confirm what the patient understands. Relative presence at any visit is crucial and very important. And for us, we notice that they will come with the relative, or they might come with any caregiver, like a nurse or we call it caregiver at home, even from day home care. So in examination, we need to observe the patient to assess strength, mobility, and the ability to follow instruction. Rising from chair, if she could stand, crossing her arm across her chest, this is a good sign that she have good strength to stand and balance. Moving toward the bed will give us a lot of information about her functionality and her body activity to reflect on us how far we can go with the examination and how bad is the situation. If she could do this, no need to even examine her, and we'll tell you why. The utility of pelvic examination without pap smear in older women is unknown. As I told you why, because they are not really clear about the when to stop the screening. So usually you need to examine, not putting in mind that we have to take the pap smear. It's the least. Dangerous pathology is rarely detected in the cognitive intact, healthy, asymptomatic person. That's why if we have cognitively impaired women, examination is very, very important because we need to reach to the disease. We need to position them very carefully. Hip and knee problems always there. We need, during the history taking, we need to make sure that she's not having any previous surgery or any replacement, any restriction of the movement and the abduction. Extra pillow might be needed to help in dorsal kyphosis to make her more comfortable during the examination. Topically, Dukan applied to the vestibule will help a lot to minimize the pain and make her more comfortable. Doing the examination while she's standing might help us a lot in diagnosing the degree of the prolapse that she might have in the pelvis that we cannot examine while she's lying down. We will talk about it, but it can cause a lot of problems and complication if it is not diagnosed completely, especially the extent of grade 3 and 4. So what are the most common complaints? Usually they will come with benign breast pain, let's say, and which is need to be seen. So sometimes they are referred to gynecologists, although this is a surgical problem, or they can go to the primary healthcare initially, but we see them frequently for that. So mastalgia can be the presenting symptom for medical condition or disease in non-lactating structure like vasculature, connective tissue, and lymphatic and nerve. Breast lesion could be manifestation of metastatic lung cancer, Wegener's granulomatosis, sarcoidosis, other skin disease, tuberculosis, or even syphilis. Other differential diagnosis, it can be something totally away from the breast, but can cause breast pain. That's why the examination and going further beyond the examination and testing the patient is very important. So cholecystitis might be a reason, hiatal hernia, gastroesophageal reflux, herpes zoster, and so on. The other complaint might be lower abdominal pain. Well, this is very, very common. So lower abdominal pain, to rule out gynecologic pathology, is one of the most common referral to our clinic. So while reproductive organ is uncommonly causing the pain, in the elderly, myofascial pain is common and often overlooked, also called chronic abdominal wall pain. The diagnosis and the treatment of this problem is very simple and inexpensive, and always we need to rule out fecal impaction that might affect a lot of her symptoms that might let us think of something really malignant or something more aggressive than simple fecal impaction. Other diagnoses can be diverticulitis, constipation, functional bowel disease, neuropathy, herpes zoster, as I mentioned in the breast pain, nephrotic problems, renal, abdominal wall hernia, and even tuberculosis. Again, fecal impaction can play a big role at the end if we could rule out every cause. Third most common complaint is postmenopausal bleeding, and always they will come with a fear of cancer, especially with their relatives. So the differential diagnosis of postmenopausal bleeding in older women include neglected pessary, cervical or rectal polyp, which all are still benign, urethral prolapse, vulvovaginal cancer, or non-uterine condition that require some care. The risk of cancer is higher the older is the lady. So especially at the age of 70, we can consider the endometrial cancer is more common than younger age. The incident peaks, as I said, between 70 and 80, with relatively increased risk with type 2. The problem with type 2, that's very difficult to diagnose by ultrasound because it will show you thin endometrium, but persistent symptom. But that's why sometimes you can miss, even while we are taking the pill, you can miss that type of cancer. That's why sometimes rushing the patient to hysteroscopy and directed biopsy might be really important. So the routine investigation that will be done at the clinic for this very important complaint is transvaginal ultrasound, where we will assess the uterus, any other pathology, and the endometrial thickness, other pathology like polyp, collection of fluid, and doing the PIPL at the same session, or direct referral to office hysteroscopy or hysteroscopy, where we don't prefer to do that because she might need to go under anesthesia. So if the cervix is stenosis, we might struggle a little bit in the office to do that. If the endometrial thickness is less than 4 millimeters by ultrasound, we can continue to follow her up because we might face some problem to enter the cervical canal and take the biopsy. So if she persisted to bleed, even the endometrium is less than 4 millimeters, we need to go further and give her something to soften the cervix, like misoprostol. Then we will try again for people in the clinic. We can do some techniques which is considered to be creative, like taking the sample under ultrasound guidance, where it will direct you toward the cavity without causing too much harm to the patient. So the usual follow-up, as I mentioned before, but in summary, that you will see, take the history from the patient, do the initial ultrasound, and according to the ultrasound, if the endometrial thickness is less than 4, you have the option to wait and observe, because most probably it might be atrophic. If the symptom persists, you need to go further and do the sampling. If it is more than 4, you need to sample her or do hysteroscopy. If you found any clear pathology by ultrasound, you need to refer her for treatment. And the same thing if you didn't do ultrasound and you want to go direct and do endometrial biopsy. If it is normal result and she continued to bleed, and there is suspicion that there is a pathology, you can go further and do hysteroscopy, saline infusion, or observe. It depends at the end how far is the patient in her general situation and how far we can go and intervene. The finding that we can see it in ultrasound varies. Usually, if we will go through the first one, it is thin endometrium, more reassuring, so we need to observe. And if we saw something thickened like that, we need to take a biopsy. Collection of fluid is not a benign sign. We have to observe it closely. It will be considered benign if we are suspecting a cervical stenosis which collect fluid behind. Other than that, we need to sample it or scope it. If we have also a lesion that might be a fibroid or polyp, same thing, need to be removed and sampled. Polyp also need to be removed, although most of the time they are benign. Thick polypoidal endometrium with some fluid collection also need to be sampled and scoped. Applying Doppler is very important because high Doppler flow will give you a clue that it is a malignancy. So high Doppler flow with thick endometrium is a malignancy, so we need to take it serious and we treat according to patient general situation. Then we have the vulval and vaginal condition. Both aging and long-term estrogen deficiency increase the vulvar susceptibility to trauma and decrease immune function. Most common are atrophy is number 1 always, lichen sclerosis and candidiasis, especially in obese patient or patient with diabetes. So usually we can see the change in the mucosa, loss of the normal texture of the mucosa, so which can be sometimes combined with other problems. So sometimes you can find an atrophy plus irritation from the long use pad or the care of that's taken to that patient is not optimum, so it can cause local irritation only, in addition to the atrophy. So she will present in worse situation, like sclerosis with candidiasis combined, or secondary bacterial infection in diabetic patient, which mean also poor hygiene and poor control of blood sugar that can lead to secondary infection other than candidiasis. So atrophic vaginitis, usually it's easy to treat, but we need the consistency in the treatment. So we can know it simply from the vulval architecture, and it will give us an important clue. Absent of distinct labia minora will give us a clue also.
Fatima, sorry to interrupt, there's 5 minutes left.
Okay. Biopsy might be very important basing on the clinical impression. So usually topical estrogen, moderate hypotensive topical glucosteroid. Sometimes we like to give them some barrier oil or mineral oil or even Vaseline to keep a layer between the mucosa and the cloth. Laser can help a lot, but depend again on the patient need. So if it is the atrophy is the main thing that can cause all this problem and can cause bleeding and some urinary problem, here we need to do laser. Other than that, we can try the estrogen, then see next. Vulvar cancer need biopsy for sure, as we mentioned, need close follow-up. We need to rule out other problems with the cancer is, that can be mimicking, like initially if you start with like in sclerosis, then it can change to cancer. So having some signs and symptoms that indicate it might be a cancer is very important, like asymmetry, bleeding, change, worsening of the symptom can do a lot. Vaginal discharge usually not due to infection, most probably due to a discharge that's not related to bacterial or fungal, but it might be to cervical stenosis, fistula formation due to pessary, all usually they are malodorous. What about, I'll skip the UTI, which is very common, and it can be treated easily with antibiotic, although they don't respond to the antibiotic like young people, but because of the comorbidities and the resistance. But we need to treat them if they are with bacteriuria and symptom. But if it is only bacteriuria with no symptom, no need to treat. It's considered contraindicated. What about nocturia? It's a life, it's disturbing, and it can cause fall and fracture and worsen situation and prognosis in future. So we need to rule out a bladder problem, fluid problem, and sleep problem, and investigate them before we treat them, because we know that cholinergic medication is not really, I mean, tricyclic antidepressants are not really the easy thing that we can use from the beginning to improve those symptoms. Incontinence is very important. It's very difficult to differentiate between urge and mixed and overflow incontinence. It's very important to take proper history and try to diagnose the problem of incontinence in general, but no need to differentiate which is which. So behavioral therapy will play a role in all of them. Pelvic floor muscle training will play a role in all of them to improve it. Even weak Kegel exercise can improve a lot of the outcome of the incontinence. We can go with low doses and slow doses of medication like VisiCare, we use it now. And we need to be careful with medication interaction and side effect. PCR is for prolapse, and it is one of the best modalities that we use it with the patient, especially that they are not a good candidate for surgery. So inserting pessary is an art. So we need to evaluate her very well, considering all the other problems like the size of hiatal, genital hiatus, vaginal length, hysterectomy, pelvic reconstructive surgeries, hair parietes, and other problems. So we can continue it if it is suiting her, and we can discontinue if there is no benefit and she might need surgical intervention to decrease the anxiety and improve the situation. So if you put the pessary, she needs to change it every 1 to 3 months. She can do it herself. We can do it for her if she could reach to our clinic, although we had some problem with COVID timing that we couldn't do that easily, but they had to come and change because we have one type of the pessaries, which is the cube. It can cause a lot of erosion and problems. So the most common problems are or complication, expulsion, pain, bleeding, incarceration, and ulcer formation that we need to treat them with a lot of modalities, following up the patient, giving her primary cream, which is estrogen cream that will improve the mucosal findings. So to conclude, most individuals luckily enough to age will become vulnerable. So proactive guidance toward medical, social, and legal resources help a lot of those patients to diminish with diminished capacity to maintain their functionality and continue in better status. Visiting gynae clinic will help طبعا a lot to tackle those problems gently. Thank you very much.
Thank you, Dr. Fatima. This was interesting presentation, interesting information. So we'll move to the next speaker. It's Dr. Waleed Al-Malik. He's the consultant geriatrician. He's the head of geriatric medicine unit and family medicine department in King Abdulaziz Medical City. Dr. Waleed has more than 25 years of clinical and academic experience. He published several papers and books, and also he's actively participating in local and international conferences. Dr. Waleed will gonna give us a talk about evidence-based approach to constipation in elderly in different settings. Go ahead, Dr. Waleed.
السلام عليكم ورحمة الله وبركاته.
Salam, Dr. Waleed.
Thank you very much, Dr. Ali. I'm so glad, Dr. Abdullah, I'm so glad to be with you in this eminent geriatrics conference gathering in its fourth year, I guess. And hopefully you will find this talk from a distance helpful and encouraging. So let's start saving time. You know, constipation in elderly is very common, and some studies have shown that 50% of bedridden or bedbound patients has one-time or occasional constipation episodes. And it's also accounted that 30% of people with who are 65 and above also will experience constipation once at least in their life. So it is a very common a problem, a very common, let's say, disease that has to be tackled and addressed during our clinical practice. So constipation is defined as people sometimes misunderstood the definition of constipation as if they think it's only frequency. Constipation is not a problem of frequency of passing or opening the bowel. It can be normal frequency. So there is like a consensus about definition of constipation that has been defined as a stool frequency less than 3 weeks with some symptoms like lumpy hard stool, straining at defecation, or suffering during defecation, and also taking long than it's supposed on the toilet or commode. Also a feeling of incomplete or inadequate emptying or evacuation of the bowel is also considered one of the what considered like one of the cardinal symptoms or collection of symptoms of constipation.
Sorry, doctor, please let me know when to click next on your presentation.
Yeah, can you click next, please? So quickly, we'll go on anatomy. You know, the gastrointestinal tract is like maybe is the biggest or the longest organ in our body. So the GI total length is almost 30 feet, which carry a lot of functions that not only digestion or swallowing, it's also can be considered like an endocrine disease. Many hormones and enzymes and also exocrine organ can be handled and worked on this big organ in our body. So it's also absorb food and excrete waters and eliminate waste and some elements and work as we said, metabolic regulator. Next slide, please. Yeah, can you go? Yeah, please. There is a part of the GI tract in oropharynx, esophagus, stomach, duodenum. Next slide, please. And also, then we go to small intestine. Next slide. Which also take like 20 to 24 feet long, which is the biggest or the largest or the longest piece of GI tract. And the food moves via this long tract, long lumen, which takes at around 1 to 3 hours to be conveyed or delivered to the ileocecal or the start of the large intestine. So go to the next slide, please. The basic rule of large intestine is to extract water, to lubricate stool, and to pass water and excretions, feces from and expel it from our body. Next slide, please. So the colon, where the material is transported via a segment contraction of the involuntary muscle, mesenteric muscle, and the muscles of the wall of the colon, and it may take like 24 hours to 40 hours to 48 hours to be expelled outside. Next slide. Rectum and anus, which is the final part of our GI tract, which collect and coordinate and voluntarily allow for defecation and passage of our stool. The work of the function of anus and rectum is a bit complicated, which can play with like brain and smooth muscle and neurons, peripheral and central neurons. Those has to play in a coordinated, smooth way to sometimes they work in an opposite way to expel the feces and excretion. We need some relaxation of a muscle. We need some like contraction of smooth muscle, and at the same time we need relaxation of the sphincters, the anal sphincters. So contraction and relaxation at the same time is considered a very complicated problem, for which sometimes the disorder of defecation, which some people are call it colonic or anorectal dyssynergia, is a big problem in maybe around 30 to 40% of people who are diagnosed with defecation of disorder. Next slide, please. So feces in general composed mainly of water. The remainder is dead bacteria and some fibers and some sloughs and some bilirubins, fats and salts. So mainly consistent of water. Next slide, please. So what is the common causes of constipation in elderly? I just list them. If all people are not active or physically inactive, they may suffer from a problem with normal passing or frequency of passing stool. Eating disorders has a rule. Overuse of laxative, which is very common in our geriatrics list of medication, which can give like a rebound or opposite side effects. So the overuse of laxative can make our GI more lazy, especially with the muscle stimulant. Inadequate fluid intake, low fiber diet, some tumors and other obstructing masses, irritable bowel syndromes, which is an idiopathic, or some people refer to as a primary cause of constipation. Some neurological condition, either like central or peripheral, like Parkinson's disease, multiple sclerosis, or pelvic floor injuries, rectocele, prolapse. All these can affect the peripheral neurons and affect normal passage of stool. Disability, as we said, people who are in wheelchair or cannot move, they have also noticeable chronic ongoing constipation. Lack of privacy also in some people who reside in nursing home can suffer this problem as well. Next slide, please. If we go to the medication that affect the normal process of constipation, which is too many medications that is necessary for our elderlies, unfortunately can cause constipation. So name it, analgesics, opiates, calcium channel blockers for hypertension, antacids, calcium supplement, iron supplement, antihistamine, diuretics, antiparkinson, uh, alpha adrenergic blockers, medications for incontinence. So a lot of medication that is that we all find it in our patient pockets or patient basket, uh, unfortunately is a cause of constipation, or we can call like this is the secondary cause of constipation. What are the signs and symptoms? Next slide, please. What are the signs and symptoms of constipation? A passage of dry, hard stool, passage of liquid fecal seepage, and sometimes spurious diarrhea. So it's not only hard or lumpy stool. Sometimes liquid stool is considered as a constipation. And that is very obvious when there is a fecal impaction with overflow diarrhea. So we have to, we probably will go to the Bristol scale and see these changes or see these variation in stool uh, consistency. Straining also considered one of the sign of or symptom of stool. So when a patient goes to the toilet and he keeps straining his muscle to pass a stool, is considered also cardinal symptom of constipation. When there is an associated nausea and vomiting, where we can inspect like or think about obstruction is going on. Anorexia, abdominal pain or tenderness, abdominal distension, headache as well, pain with defecation, all these symptoms. So as you see now, the symptoms are too many. So it's not only a frequency. We can get constipation with a normal frequency, 3 or more than for bowel movement a week, which is considered normal. However, we can still consider to be constipating patients if there is one or more of these symptoms. Next slide, please. Complication is nasty sometimes. If neglected or inadequately treated, constipation soon lead to other symptoms and complication. Anorexia, nausea, vomiting, overflow, diarrhea, or as I said, like due to fecal impaction, fecal incontinence, urine incontinence, retention of urine, UTI, functional intestinal obstruction, delirium, which is a very common cause of fecal impaction and chronic constipation. Rectal prolapse, especially in female, can be a result of chronic constipation. Anal fissure as well, chronic back pain, hernias, hemorrhoid. So these are very nasty in elderly, very nasty complication can be manifested, can be resulted in if not, if constipation is not tackled early. Next slide, please. This is the Bristol stool chart where everybody knows it. These are the type of stool content, stool consistency. So type 1, where there is like a hard, lumpy